program and you're at the whim of someone who doesn't have necessarily your best interest at heart to make your program successful. And that just gives you a breakdown of how many places are separate divisions. One of the complaints about hospitalists is discontinuity. And the primary care provider, the PCP, says, I know this patient. So you're working at the Newman Clinic, famous Newman Clinic that doesn't exist, and you say, I know these patients, I'm going to go to the hospital and take care of them. Or because I know what's going on with them. But I don't really know that hospital that well, and I only spend an hour there, a day at most, maybe a half hour. I try not to go at all if I don't have to. And so I may know the patient, but I may not know what's going on in the hospital. So on the other hand, here's the hospitalist. So the primary care provider may not communicate as well as they should with the hospitalist, and that's something that we've been working on very hard. That's a huge issue. But you look at the hospitalist, he knows the hospital. He's there all the time. He knows where the ER is and all the ER docs. He knows where the ICU is. He goes up to the ICU and sees the patients there if need be. He's hooked into the radiologist. He knows how to get his studies done at 3 o'clock in the afternoon. If he wants a CT guided biopsy, he knows the guy to call to get it done. He knows the process. And he's there, he knows the consultants. He's there to do consults. And when the family says at 3 o'clock in the afternoon, the only time we can get together for a family meeting is at 3, he doesn't have an office full of patients. He can make the time, or she can make the time, to be there with the family meeting. So it's that availability, which is huge. So, and here's like a typical schedule. You can see that the hospitalist is on the wards all day. Maybe in a 2-week or a 1-week run, they're there all the time. And that gives you that within the hospital continuity, which makes a huge difference. I want to point out one thing, though. The hospitalist is not the intern of the primary care provider. So you don't have a doctor in a clinic building calling you and saying, I think this patient should be on a different antibiotic than you're giving. You don't have the hospitalist calling the primary care provider and saying, hey, can I get a CAT scan on your patient? If that's the model for hospital medicine, you can forget about it. It's not going to work. It just won't work. You have to have the hospitalist in charge. And I'll show this picture. Have you ever seen this movie, Moby Dick? Anyone seen this movie? It's a classic old movie, Moby Dick. And there's Ahab. He's the captain. I like him. Plus, he's got a nice scar. And that's Gregory Peck. A ship only has one captain. Okay? You don't have 3 captains on a ship. And the hospitalist has to be in charge of the patient when they're in the hospital. That a representative, they need to be able to order their tests. And if you have primary care providers who are coming on the floor and saying, don't do that, or calling and saying, don't order anything on my patient until I approve it, hospital medicine is never going to fly. Then that's not a career. You're just an intern for life if that's the case. So if that's how you see your outpatient colleagues see hospital medicine, as you just being their we call it a scut monkey. That's a derogatory term for someone who just does all your paperwork and is not really in charge of anything. If that's all a hospitalist is, then that's not a career that anyone would want to do. So